Hi, my name is Alexandra, and I'll be presenting on mind-body practices for mental health patients. 43.8 million. That's the number of adults that experience mental illness in a given year. 1 in 5 adults in America experience a mental illness, and we're talking schizophrenia, bipolar disorder, depression, anxiety. Those are among the most prevalent mental health issues today. And not only is depression the leading cause of disability worldwide, it is also a major contributor to the global burden of disease. Suicide ranks 10 in leading causes of death in America, and 90% of those who die by suicide have an underlying mental illness. Mental health is a growing public health concern that is often overlooked, buried under the weight of more immediately life-threatening diseases like heart failure or cancer. However, mental health has profound effects on one's physical and psychosocial well-being. So what are the consequences of lack of treatment? According to the National Alliance on Mental Illness, or NAMI, people with psychological disorders are at greater risk for decreased quality of life, educational difficulties, poverty, and health problems. Adults living with mental illness in America die on average 25 years earlier than others, and this is largely due to treatable medical conditions. Serious mental illness costs America $193.2 billion in lost earnings every year. The psychiatric patients are a unique population that I feel demands more evidence-based research. This population is currently overwhelming my workplace, the emergency department at LGH. We as ED nurses care for critically ill patients, we receive ambulances unexpectedly, and we try to keep our beds full to accommodate ED overcrowding and reduce patient wait times. So this leaves inadequate time for providing dedicated therapeutic mental health care for the growing psych population that we see. So working in this environment gave me a sense of urgency and curiosity to address what cost-effective interventions ED staff may implement to improve therapeutic care for our psych patients. The purpose of this project aims to investigate the effects of mind and body practices on mental health patients. The research question is, do mind and body interventions of meditation and aromatherapy decrease anxiety and depression compared to no intervention in psychiatric patients? For the PICO format, the P stands for population, and that is psychiatric. The I, intervention, is meditation and aromatherapy. The C, comparison, is no intervention. And the O, or outcome, is decreased anxiety and depression. The literature search involved the database CINAHL, which was retrieved from Pennsylvania College of Health Sciences library. And the search terms included mental health, psychiatric patients, mind and body practices, meditation, and aromatherapy. Chosen articles were published within 5 years, so the range was from 2013 to 2018. To further refine the results, articles were limited to full text, peer-reviewed, and scholarly selections only. Excluded from the search were secondary sources, systematic reviews, and pediatric studies, as I only wanted to focus on the adult population. So in reflection, I work in emergency medicine. So originally I intended to find research on mind-body practices for psychiatric patients in emergencies so that I may apply my findings to my practice specifically. However, finding research on mind-body practices for psych emergencies was too specific of a topic, and it didn't produce many results. So I found that aspect challenging. But by broadening my topic to the population of psych patients living with both acute and chronic issues, I was able to expand the availability of research studies. And still, despite the growing family of mind-body practices, supportive research studies were limited. Chartres conducted a 2-arm, single-blinded randomized control trial on adults who were on stable antiretroviral treatment for HIV. The intervention was a 6-month duration program of meditation twice a day for 20 minutes. The control group underwent a healthy eating education program for a comparable length of time. And the outcomes were that stress reduction was associated with decreased chronic stress, which was associated with reduction in depression, anxiety, and improvement in emotional well-being. It also demonstrated, which is interesting, improvement in CD4 count, natural killer cell number, and safer sexual practice for this HIV population. The analyses used were t-tests and also blood draws for serum norepinephrine and cortisol levels to measure the endocrine response. In comparison, Bosson, he conducted a single-arm trial at Massachusetts General Hospital Hypertensive Clinic, which involved adult patients diagnosed with stage 1 essential hypertension. They were not receiving antihypertensives. And so over the 4 weeks, patients received a relaxation response-based intervention. And what they found was that increasing evidence supports mind and body interventions for treating chronic illnesses. And they linked the relaxation response intervention to decreased levels of anxiety and depression in patients with hypertension. Although the decrease in systolic and diastolic blood pressures were statistically significant, not all patients achieved improvement in blood pressure that was clinically significant. But they did analyze transcriptional gene changes, and they showed significant upregulation of genes linked to endoplasmic reticulum stress, DNA repair, and kinase activity after the relaxation response practice. Like the first study, they also used t-tests, but they also used microarray quality control analysis and transcriptome analysis to analyze the changes in genes. For psychological effects, Kuyken started with a 24-month randomized controlled trial that was conducted on adult patients with 3 or more previous major depressive episodes, and they were also on a therapeutic dose of maintenance antidepressants. And he wanted to investigate beyond wellness and look at whether meditation could supplement traditional treatments for depression. So 212 patients were randomly assigned to the mindfulness-based cognitive therapy, and 212 were assigned to the maintenance antidepressants. He used Cox regression and t-test analyses, and the outcome was that the time to relapse or recurrence of depression did not differ between either groups. Both treatments were associated with positive outcomes in terms of relapse or recurrence. So it's basically saying that the mindfulness-based cognitive psychotherapy was found to be as effective as medication in preventing relapse for people with recurrent depression. It also found that there's significant protection that can be provided for patients at an increased risk due to history of child abuse. And another interesting thing is that Kuyken used cost-effective analysis to show that their study did not support cost-effective hypotheses. So it was no more cost-effective than antidepressant therapy. Losch performed a case control design study using a sample of 115 patients with chronic diseases who used meditation and matched them to a control group of 115 patients who did not meditate regularly. And what his data found through questionnaires was that those who meditate regularly demonstrated improved pain-related quality of life and increased satisfaction with their life. My literature synthesis for aromatherapy produced a lot of research that was outdated, so there's limited research that suggests physiological benefits from aromatherapy. However, Chamine and Oken did find that verbal suggestion of aromatherapy effectiveness might underlie some changes in behavior and brain function after exposure to aromatherapy. So the results basically indicate that simply telling people that there are positive effects and enhancing their belief system about aromatherapy might be beneficial for its performance. For psychological effects, Hahn found that the intervention group using a 15-minute diffusion period of bergamot essential oils in participants that were waiting in a room at a mental health treatment center, they reported 48.77% higher score of feeling proud and 43.36% higher score of feeling active. However, the active group also demonstrated a 60% increase of feeling nervous. This quasi-experimental design that used non-probability convenience sampling did not produce any findings that were statistically significant. However, they were clinically significant, indicating that there is a behavioral component to the efficacy of aromatherapy. In synthesizing the literature, I categorized the data into physiological effects and psychological effects, which had a huge impact on the organization and consistency of my synthesis. One challenge I did experience was the comparison between meditation and aromatherapy, because they are two entirely different practices. Bosson used a 20-minute meditation period in which he encouraged diaphragmatic breathing, body scan, repetition, and meditation. He also provided an audio CD, which is something that is recommended for patients to take home. Another recommendation is lavender oil, which was proven by Chamine and Okun to assist in relieving symptoms of stress and anxiety. Barriers include inadequate education, safety issues, developing policies and protocols, as well as cost and funding. Mental health is a global health priority. Meditation can be used for this population to improve physiological and psychological well-being. And while not statistically supported, aromatherapy may still be used only after a thorough respiratory assessment and allergy review. Thank you.